Good afternoon. On behalf of Pelham Medical Center and Spartanburg Healthcare System, I welcome everyone and thank you for joining us today. I'm Lindsay Lewis, the Interim Manager of Community Outreach. Before we get started, I wanted to tell you about upcoming programs. On Wednesday, January 13th, Erica Moore, Certified Diabetes Educator, will again be presenting her program on whole food, plant-based eating. Many have asked us to repeat this class, and Erica graciously agreed. Please sign up on Spartanburg Regional's website. In addition, we will be having a heart-focused presentation in February, and our certified Titleist Performance golf specialist will be presenting a golf-focused class in March. Those dates are currently being finalized, so watch our website for registration updates. If you have questions in the upcoming presentation, please type them in the Q&A box, and I will ask them to Dr. Briski at the end of the presentation. And now it's time for our presentation, titled, We've Got Your Back. Our speaker today is Dr. David Briski, a spine specialist with Orthopaedic Surgery, Pelham. Dr. Briski attended medical school in Australia and completed his residency in New Orleans. In addition, he completed a fellowship in spine at New England Hospital in Boston. Dr. Briski is both board eligible for the American Board of Orthopedic Surgeons and board certification. We are very pleased to have Dr. Briski join us today for his presentation. Welcome, Dr. Briski. I will now turn this presentation over to you.
Thank you very much for that kind introduction, and thank all of you for being with me here today. As Lindsay said, we're going to talk about the spine today, and so let's get going. So to first understand what exactly is going on, it's a good idea to start with the basic anatomy or the structure of the spine. As surgeons, we break it down into 4 or 5 different sections. The first is the cervical spine or your neck. There's 7 cervical spine bones. They support your head. They're responsible for the movement of your head. And there's certainly a lot of things with arthritis and pinched nerves in your neck that we can talk about. But just like with the lower back, it's fairly complex and it's better saved for another day. And I look forward to sitting down with all of you to have that chat in the future. The thoracic spine is kind of the support for your chest, for your heart, for your lungs. All of your ribs attach at the thoracic spine. There's 12 bones or 12 vertebrae in the thoracic spine. It's primarily responsible for rotation. So if you're sitting in your chair and you twist back and forth in your chair, that's your thoracic spine that's making that movement. The part we're going to focus on today is the lumbar spine. There's 5 lumbar vertebrae or bones. And in your lower back, it's responsible for really bending and extending as you go to pick things up or move around in your daily life. The anchor of all of this is the sacrum. There are 5 bones that fuse together while you're growing in the womb and come out. And what happens is they form the framework that goes to your pelvis. So if everybody feels on the side, they have hip bones that you can feel higher up. The sacrum attaches there, and people sometimes will have what's called SI joint pain, which is just a fancy word of saying that the joint between the base of your spine and your pelvis has some irritation in it. Finally, the coccyx or your tailbone, if anyone knows someone who's fallen directly on their bottom and has a lot of pain sitting for 4 to 6 weeks afterwards, this is the actual part that you break when a doctor tells you that you break your tailbone. So when we zoom in and we look at the actual vertebral bodies or the bones themselves, it's important to understand that the structure of the spine is designed to basically support you, keep you standing up nice and tall, and provide both a soft cushion as well as a hard framework to protect the spine as well as the nerves. When we look, you can see the spinal cord on the right of this image that runs in the canal all the way down from your brain up top down to where your legs are. And the picture on the left, you can see that triangle shape or the opening there, and that is where the actual spinal cord runs. And the gaps are where the nerves actually come out. So the lamina, which you can see highlighted there, is the back protection of the bone that protects the spinal cord in your back. The spinous process with the arrow is that bony part that you can feel easily in the back of your neck, and then sometimes also in the middle of your back and also farther down. So the question is, when we get to the level of the disc is really the shock absorber of the spine. I like to tell people that it's easiest to think about the spine much like a car. The goal is to protect yourself while also provide cushion. The bones, or the actual blocks of bone, and the spinous processes and the lamina that we talk about and all these different names are the actual strength and structure. The intervertebral disc is the shock absorber, and its goal is to protect impact from walking, jumping, running, exercise, or other activities of daily life from damaging or hurting the spinal cord or the nerves where they come out the sides. So let's transition to common conditions and treatment. A herniated disc is one of the most common things that we see as spine surgeons, and one of the most common things that I hear my patients talk about, whether it's a slip disc, a ruptured disc, or a bulging disc. They all kind of say the same thing, that the shock absorber has kind of broken down a little bit and it's causing problems by putting pressure on the nerves. As you can see highlighted in the picture, when that disc comes out and puts pressure on the nerve, it causes inflammation. That inflammation is what you feel in the form of pain or numbness that comes down the leg. This is a very good picture because it shows on the left a normal looking disc. What I like to tell all of my patients when we look at their imaging, whether it's an MRI or x-rays or go through models, it's nice to kind of think of the disc almost as a jelly donut. You have the blue section on the outside, which is kind of the firm casing of the disc or the shock absorber, and the pink in the nucleus is actually the jelly. When somebody stands up or they have an acute disc herniation where they have a lot of back pain or sciatic type pain down their legs, what I tell them is that they got squeezed and they had pressure across that level. And what happened is some of that jelly kind of squirted out and is now sitting, as you can see on the right picture, and pushing on the nerve in the spinal cord. And that's the pain that you feel. Whether it's acute or immediate or over time with just general aging, it's this issue that causes a lot of problems with spine patients. So what are the risk factors for this? First and foremost, I think that being active is the most important thing that you can do to prevent problems with your back. Sedentary lifestyle goes along with the opposite of that. And I'll take this moment, which I think I will discuss later as well, but hip and core strength, having strong abs and good posture over the length of your life and with everything that you do is the best thing to do to prevent your back from giving out on you. People that drive a lot, we've used the analogy of your discs being a shock absorber, and you can imagine that if you spend a lot of time driving on the roads, that all of that motion and all of that little vibration from spending time on the highway or driving around the roads of South Carolina, that we have a little bumps here and there, and that certainly can cause some degeneration. Coughing can sometimes lead to it if it's a chronic cough in nature. Smoking is perhaps one of the most challenging things because it causes a lot of damage without actually seeing it. It prevents blood flow to the discs and it causes the discs to not be able to heal properly or stay healthy. Frequent lifting, manual labor, those kind of activities with or without good posture can also cause herniated discs or disc degeneration. We see this most prevalently in people from the ages of 40 to 60. The way in which people herniate discs or have symptoms related to them varies by age. People that are a little bit younger tend to be having a little bit more activity and have more of an acute disc herniation. People that get into their 50s and their 60s tend to have degenerative discs that aren't really bothering them, then have more activity or do some heavy lifting or change their activity a little bit and cause that pushing, that pinching, and that inflammation. And then they come to the doctor and they say, what can we do about this? As I said, the symptoms are primarily pain, that classic sciatic type pain that people feel. The body, I like to say, and the nerves are kind of like a wiring grid. And as doctors, what we do is we look within that wiring grid to say what muscles are not working properly and where exactly do you feel the pain that's coming down your legs. It very much helps us to figure out which exact level we talk about. And anybody who knows a spine patient knows that they talk about, well, I have a pinched L4-5 nerve or a pinched L3-4 nerve. And that's us using our understanding of the anatomy that we talked about to figure out what nerve is actually the problem. When the symptoms become severe, they can sometimes lead to weakness in those muscles. They can lead to numbness down the leg, and they can lead to that tingling sensation, like if you hit your funny bone, that may or may not go away or may not be worse at certain times of the day. So the question then becomes, what do we do about it? I tell all of my patients that spine surgery is elective until it's not elective, meaning that if patients have weakness or other significant problems, that tends to tip our hands more toward aggressive management, such as surgery. But certainly every single patient that comes to the office, I like to try everything that I can do to avoid surgery because it's still a quality of life issue and there's plenty of options to improve your quality of life without jumping right to surgery. The most important thing is lifestyle changes. Activity modifications are doing things to improve your core strength. As we've talked about, inflammatory issues in the nerves from the nerves being pushed on is the reason why we have that pain. So medicines that treat inflammation, like NSAIDs or anti-inflammatories, are really the best medicines that you can use to try and control that nerve pain that you get and the pain and discomfort that you get in your lower back. When those medications and those modifications fail, a little boost shot with an epidural steroid injection is really the best thing, because what it does is it actually takes that steroid, which is a very powerful anti-inflammatory, and rather than trying to use your whole body with medications, we put the steroid medicine directly around the nerve and almost give the nerve a bath of steroids, which allows all of that medicine to work directly on the nerve that's causing the problems and can last in some cases 4 to 6 months or even longer. When all of those things fail, we have no other option, if the quality of life that you have is not what you want, to discuss surgery. The surgery of choice is what's called a microdiscectomy, which is a way of saying that we make a very small incision and we go and we remove the pressure on the nerve because the pressure is what's causing the inflammation. It's a combination of two things. First, we decompress or remove the pressure on the nerve and the spinal cord on top by removing a small part of the lamina, which you can see in the picture in the bottom right. The second thing that we do is we gently pull the spinal cord out of the way and we find that area of the jelly donut that has popped out and is sitting where it should not be, and we put that and we take that out and remove it. People often ask me, well, what do you put back? And the answer is we don't have to put anything back because that section of disc is already kind of squeezed out and it just needs to be removed, and there's nothing that needs to be put back in its place in this situation. When we talk about disc herniations, these are things that happen on a more acute basis, or something happens and then all of a sudden you have symptoms. Spinal stenosis is a different animal, and by that I mean spinal stenosis usually comes from wear and tear and just living a good, healthy life. As the shock absorbers give out, people probably have noticed that as you get older, you get a little bit shorter. And so those shocks give out, the discs tend to bulge when people talk about bulging discs. And what that can do is that can put pressure or pinch the spinal canal. You can see in the picture where it says normal, you can see all the little nerve roots of the spinal cord, nice and socially distanced. On the right, you can see how they're all pinched and pushed together. And when you have that, you get symptoms that are somewhat similar to a herniated disc, but at the same time, a little bit more general. And what I mean by that is people often complain that when they stand up straight, they get a lot of back pain, and that back pain can travel down their legs, through their butt, into the back of their hips. And if they bend forward or they sit down, their symptoms improve. And a lot of times they need to use a shopping cart to help with their symptoms. Now, this is not an issue with blood flow or with the muscles themselves. So when you're sitting and you're opening up your spinal canal to allow those nerves to breathe, you'd have no problem if you were to sit on a stationary bike or even walk uphill or upstairs, because we have to lean forward to do those things. So this illustrates once again kind of the symptoms that people get. And when you're standing and you're walking up nice and straight, you have a pinching of your spinal cord because that canal gets more narrow, and that causes the symptoms in your back, down your legs, and just causes a general discomfort. One of the questions I ask all of my patients is that if you go to the grocery store and you're leaning forward or using a shopping cart to walk around, does this help alleviate your symptoms, and are you able to walk farther because of it? If the answer to that is yes, then more likely than not, then there is some degenerative changes that are going on, which are normal for almost everyone, and that is the likely cause, or at least partially the cause of your symptoms. Once again, we do everything we can to avoid surgical intervention because quality of life is what matters most. And physical therapy is the mainstay, along with anti-inflammatory medicines and epidural steroid injections. As I said, with degenerative disc disease and with issues of disc herniations, core strength and strong abs are the most important thing that we have, because what it does is it removes pressure on the muscles of the back, it removes pressure on the joints in the back, and all of those things relieve tension in the back, which then alleviates your symptoms. When all of those things fail, the next step is to discuss surgery. As we saw with the microdiscectomy, that was a rather small surgery to treat a rather small problem. With spinal stenosis, the surgery has to be a little bit larger. The surgery is called a laminectomy, and it's a surgery to remove the back of the spinous process, or the back of the bone, as well as that roof of the spinal canal, the lamina. And what I tell people is that when you're born or when you're young, you have, a 12-foot ceiling, so to speak, for your spine to live in. As you get older and you degenerate, that ceiling goes down to 5, 6, or sometimes even less feet high. And you can imagine that if you're walking around and you have a 5-foot ceiling, naturally you'd hit your head on that ceiling, and that's what causes your discomfort. The overall goal of the surgery is to try and restore that ceiling back to 10 or 12 feet to allow the spinal cord to breathe within the spinal canal and alleviate your symptoms. This is a very common surgery that we do all the time. And when surgeons talk about doing a decompressive surgery or a decompression, this is what they're talking about. One of the last main things that we'll talk about today is called spondylolisthesis. This is a word that means that you have a slip or a listhesis of your vertebra. This is a very common disease and very common disorder that people get. As people age, we most commonly see it at the L4-5, or the 4th and 5th lumbar vertebra, which is in fact the picture that you see here on your right. If the vertebra slips too far, you can imagine that spinal canal that we've been talking about gets pinched off, and also the canal or little spot where the nerves come out can also be pinched off. What are the risk factors for this? I tend to find in my patient populations that women are at a little bit higher risk than men. African Americans tend to be at a higher risk than Caucasian. And sports that put a lot of stress on the lower back can also be a risk factor for this. And the primary reason we say that is sports that put stress, such as extension. So people always notice that if they have a degenerative spondylolisthesis or a slipped vertebra in their back, that when they lean back or extend or stand up straight or try and look up and do something, that brings their symptoms on and their pain on more. And that's because it's loading the joint that you have on your back, the same as you have hip joints and knee joints and ankle joints. And the joints in your back degenerate, and that's what caused this problem. And so when you lean back, you irritate those joints, which make your symptoms worse. This is most common in middle-aged individuals that are older than 50 years old. So when we talk about symptoms, it's a combination of the two things that we've talked about before. When the spinal cord gets pinched off, as in spinal stenosis, that causes those pains of what we call neurogenic claudication, or the pain with walking. That's that pain that's in your back that radiates down to your butt and your thighs and really makes you stop walking. But because it can also pinch off the nerves where they come out and go down your legs, it can cause that classic sciatic type pain as well, where you can feel it like an ice pick or a sharp pain that goes all the way down to your toes, whether it's the top of the foot or the bottom of the foot, or even to your knee. And we look at all of these things to help us make a decision on what is actually going on. So, as always, the first thing that we do is figure out what we can do to improve the quality of your life without surgery. Once again, physical therapy for back strengthening, aerobic conditioning exercises, and as I talked about, extension or leaning back makes the symptoms worse. So we tend to focus on exercises that do the exact opposite, flexion-based exercises. And as a result, the one thing that improves that the most is, of course, abdomen and core strength. Medicines such as anti-inflammatories, and then when needed, epidural steroid injections also provide excellent treatment to basically manage it without having to do surgery. When we do surgery, this is where we get into the realm of what people call spinal fusions. This is where we take screws and rods and actually stabilize the spine to allow those joints to fuse together. The spine moves flexion extension like we talked about with the lumbar spine leaning forward and leaning back. And if that makes the symptoms worse because the joints are bad, then we have to stop the joints from moving. What we do is, as you can see on the left, put the screws and rods in, and then we also put something called bone graft, which acts as almost like a scaffold or a diagram for your body to heal. A common misconception is that the screws and rods are what actually cause a fusion. That's not true. We put the screws and rods in as spine surgeons to hold everything nice and still and stable so that it gives your body an opportunity to heal. To discuss disc degeneration and low back pain, it's a natural condition, it's age-related wear and tear, and the disc can cause pain, the instability can cause pain, and it can be in one level, multiple levels, and it can be in multiple spots throughout your spine. The important thing to remember with disc degeneration and low back pain is that it's natural. Every single person has it, and it's not a question of whether or not you have bulging discs or disc degeneration or low back pain. It's a question of what is it doing to your nerves? Are you weak? Do you have pain that goes down your legs? And what does it do to your quality of life? Once again, the risk factors, sedentary lifestyle, smoking, natural aging, strenuous work, all lead towards disc degeneration and low back pain. Being somewhat overweight will also increase the symptoms and the severity of those symptoms because it causes more stress on the back. And everything that we do as spine surgeons to try and improve your quality of life is to remove stress on the back. The one thing that as a patient that you can do to fully and help yourself, either before meeting me in the office or after, is to work on weight loss. So what symptoms do we have? Mild to severe mechanical or focal back pain. And again, those nerve symptoms, whether it's the nerve itself being pinched to give that classic sciatic pain, or the spinal cord, which gives you that butt pain, that leg pain, weakness, and tingling in the legs. When people have disc degeneration and low back pain, surgery is generally not the best option. What we'd like to do is have a long discussion about what we can do from a movement standpoint, from a posture standpoint, activity modification, and exercise. As I said, exercise is going to be all of those non-impact activities, stationary bicycles. Personally, I love to send my patients to what I call aquatic therapy, where we can get you in the pool and you can actually have resistance training without the weight bearing or the stress on your low back. Heat and cold therapy, whichever feels better, is a good option to use. And yoga is actually an extremely important conservative tool that I use because it focuses on flexibility and core strength. And those are the two most important things that you can have to help alleviate your low back pain and manage your disc degeneration. When we move to the medication side of things, we have non-narcotic and narcotic medications. I think that narcotic medications are not the first line medicine that I would use. It's an inflammatory process, and therefore those epidural steroid injections and those anti-inflammatories are the best thing. When pain becomes severe or people have episodic flares, they can be used on a limited basis to try and alleviate those symptoms if there's no viable surgical option. I like to tell my patients that if they are taking a large amount of narcotics to deal with the pain and there is a viable surgical option, we cannot have it where the diagnosis that you have with weakness and pain and nerve pain is forcing you to take all these medications. And that is a situation where I say that spine surgery moves more towards that necessity as opposed to an elective standpoint. Muscle relaxers for the muscle spasms and muscle tensions are very effective. And in certain instances, antidepressants can be used for alternative off-label use for the treatment of those muscle aches and to kind of help you with your quality of life. So the question then becomes, when do you go see your primary care doctor, and when does that primary care doctor send you to see me? Numbness and tingling down the legs or that classic sciatica is of course one thing to come and see, especially if it hasn't resolved in 2 to 4 weeks. An additional thing is that if the pain does not improve with rest, or you have night cramps or spasms at night and you can't sleep. If you have severe pain or injury or pain down your legs after a fall or after strenuous work that doesn't resolve with anti-inflammatory medications and rest, that is also something to come and see a doctor for. When these things are in combination of bowel or bladder changes or bathroom changes, that certainly is something that I would like to see you for in my office. And then again, listening to your body. We often say that as we get older, it's just getting older. But if you're having weakness in your legs, numbness in your legs, fever, unexplained weight loss, things that just don't seem right, that is when you go to your primary care doctor and potentially come and see me. Thank you very much for your time and your patience. At this time, are there any questions?
Dr. Briski, thank you so much for such a great presentation. I have a few questions, but I do want to encourage any of those that have got on a little bit later to ask the questions in the Q&A box. That's at the top right corner of your screen. The first question I do have is, how long is recovery after most back surgeries?
Recovery after back surgery is dependent upon the type of surgery that you have. When we're dealing with small surgeries, minimally invasive spine surgery to either remove a herniated disc, or those slightly larger surgeries, a laminectomy to decompress the spine, those I generally say are soft tissue, or your body has to heal itself. We don't have to have bones form. So anywhere from 6 weeks for all of those things to heal up and to get moving again. When we deal with fusion operations where you have a structural problem with the joints in your back that we need to actually fuse for, then recovery is not only time for your body to heal, but for your body to form bone. So 6 weeks is what I like to tell my patients for the actual healing time for the soft tissues and for your muscles to get back to normal. And then up to 6 months for those bones to heal. Okay,
thank you. The next question I have is, I'm an avid golfer. Will I be able to play golf after back surgery?
I certainly see plenty of golfers in my practice, and my partner sees plenty of golfers. I think that any back surgery that we do, the first and foremost that we look at is, can you maintain or improve your quality of life if we have an operation on you? Certainly, I would expect you to be able to golf and do everything that you can do before surgery. And if the situation was severe and significant enough where you would not potentially be able to have that same quality of life, where you're having weakness or balance issues, and the fundamental activities of daily living are challenging, then that's a conversation that we would have before surgery.
Okay, thank you. The next question we have is, why do some people with back problems have no leg pain, pain in one leg, or pain in both legs?
So that's a very good question, and that gets back to kind of the anatomy of the spine. So as we talked about, when people have pain in both legs, especially kind of in the butt and then running into the back of the legs, that's when that spinal cord gets pinched off. The body's not very good at understanding what's happening to it from a pinching standpoint. And so the only way that it can tell you that is that cramping and that pain and that sensation that you get when you stand up and you walk for a while. When you have issues and the nerves themselves kind of on the side, like we saw in the picture with the disc herniation, are pinched, the body obviously knows that, okay, that goes down to my toes or that goes down to my knees. And that's why a lot of times people will feel and experience that pain that goes right in the same spot all the time. People that have mechanical back pain from the joints and just degeneration of their discs generally don't have a lot of leg symptoms and will only have those back symptoms. And it's those people that it becomes especially important for to closely manage their weight, closely have stretching routines, and have a very good home exercise program to work on their core strength to alleviate the symptoms that they get from the actual arthritis that's in their back.
Thank you. If someone has back pain, should they rest their back or work through the pain?
So I think that initially it is certainly okay to rest the back to get through that initial phase. Anti-inflammatory medicines, heat or cold. I tend to like cold initially, followed by heat. The cold will help with the inflammation more. The heat will help relax the muscles. After the initial period, I certainly think that living and doing the activities that you need to do is the goal to get back to. And I think that if you have multiple flare-ups of this back pain, that is also a very good time to come and talk to a surgeon, to be enrolled in physical therapy, to work with somebody to design an exercise program that you can do every day as part of your normal routine to help prevent those flare-ups of back pain. Because if you can eliminate the flare-ups, then you don't have to worry about it in the first place.
Okay, thank you. Another question we have is, how would you suggest a patient to balance tolerance for pain level and when to decide on elective surgery?
It's a very good question. It gets back to, I talk to all of my patients about one thing, and the most important thing to me is quality of life. So when you have pain and when you have symptoms and you have limitations in what you can do throughout the day, that's affecting your quality of life. Every single person has a different threshold for what is near and dear to them as far as what they can do and what they cannot do and what they're willing to sacrifice. Make no mistake, spine surgery, no matter how small it is still spine surgery, and things whether good or bad can happen as a result of spine surgery. So I tell all of my patients that at the end of the day, as long as you're not having weakness where you're falling or weakness where you can't walk right and major neurologic symptoms, it really is a quality of life decision. And it may sound silly, but you deal with things in a non-operative way with the injections and the therapy and everything that you can do. And when those fail, it's either we deal with it and we work together to manage through it, or you know. And I always say, you know when you know, because it's time and everyone has their own threshold that they meet.
Okay, thank you. I know you talked a lot about core strength. One of the questions is, what exercises do you recommend for back strength specifically to core?
So, we talk about core strength, and obviously, sitting and laying on the floor and doing, 1,000 sit-ups is not going to make you better. And I would argue that that kind of motion could potentially make you worse. What I like to do is what's called isometric. It means that we are using our muscles without moving our muscles. So we do things like plank exercises, and the things that you kind of see people do in yoga, and that's one of the reasons that I like yoga. Physical therapists do an excellent job of helping to design those programs, and actually the American Academy of Orthopaedic Surgeons on their website has a home exercise kind of program and diagram that I hand out to a lot of my patients that goes through a lot of those exercises that focus on hip strength and focus on that abdominal and that core strength.
Okay, thank you. And I know you touched a little bit on heat versus cold. So one of the questions is, which is better for back pain, heat or cold?
So I tell my patients that you have to do what feels good. I think that each has its own utility. Some patients find that cold responds better because it's the inflammation and that numbing action of the ice makes them feel better. Other patients, if they have tightness in their muscles, the heat helps relax them, and then that really kind of helps their symptoms more. To be quite honest, I don't think that there's anything wrong with either of them or using them in tandem, where you can ice for 20 or 30 minutes, take some time, and then as the day goes on, at the end of the day, put a heat pack on there, making sure not to burn your skin or overheat yourself, and let the muscles relax at the end of the day.
Okay, thank you. The last question we have is, what is the best way to get in touch with you?
The best way to get in touch with me is you can see the information on this slide to call the office. I'm very close with most of the primary care practitioners, and they know that if they call me to get a patient in, I will do everything that I can. So using an outlet, either directly calling the orthopedic clinic at the number down below or calling your primary care doctor, requesting to see them or request them to have a referral put in to see me in my office.
Okay, wonderful. Well, Dr. Briski, I just want to thank you again for your time. You did such a great job with this presentation. It was very informative and we learned a lot. Again, I just want to remind everyone of our upcoming classes, so be on the lookout for those registrations. Have a great day.